Hello, Assalamu alaikum, and a very pleasant good evening to all our viewers and listeners. Welcome to tonight's program of Doctor in a House, the first program for 2026, where we continue to highlight women's issues, educate, bring awareness to you, and enable you to make better health decisions and health choices. So I am Dr. Amina Khan, specialist obstetrician and gynecologist. I currently work in the private sector, having specialized and been practicing obstetrics and gynecology for over 25 years. I am also an executive member of the Trinidad and Tobago Medical Association, where we teach, treat, mentor, and advocate. Tonight, I have a very special guest with me, who is Dr. Sean Warris, specialist pediatrician. Dr. Warris is a pediatrician whose medical journey began after graduating from medical school in 2015. Following completion of his internship, he joined the pediatric department at the Eric Williams Medical Sciences Complex in 2016, where his passion for child health continued to develop. He pursued specialist training through the Doctor of Medicine program, the DM program in pediatrics at the University of the West Indies, St. Augustine, and completed his degree in 2022. Since then, Dr. Warris has established his private practice and provides neonatal care across several private institutions throughout Trinidad and Tobago, attending deliveries, such as mine, and caring for newborns nationwide. Beyond clinical work, he is committed to community engagement. Dr. Warris regularly hosts health fairs in malls and schools, offering free pediatric assessments and education as part of his mission to support families and improve children's health across the country. Our topic tonight is a very important one, and it focuses on the role of the obstetrician and the pediatrician in promoting a healthy start to life. As the saying goes, one hand cannot clap, or two peas in a pod. So welcome tonight, Dr. Warris. Do you agree with that statement?
Oh, definitely, and thank you very much for having me.
Great. So let us start off by asking you, why is it important or necessary for a pediatrician to be present in the delivery room or the operating theater in cases of a cesarean section?
Now, that's an excellent question, Dr. Khan. So, a pediatrician is there solely for the baby, and we are there to make sure that this baby has the best start possible to life. Now, think about it like if you're building a house. A house requires a very stable foundation, and as a pediatrician, I create that foundation so that we build a strong house and with regards to a baby, a strong life moving forward, and we give that baby the best possible future. Now, it's very important that a pediatrician is there because the first minute of a baby's life can shape their entire lifetime. Now, in this first minute, we have to make sure that this baby starts to breathe, because with breathing, that delivers oxygen to the baby's brain. Now, most babies usually do well. They come out of mom and they have an excellent cry, and there's not much for us to do other than stabilize baby, ensure everything is well. However, when the time arises and some babies don't breathe, then you need expert care. Now, a pediatrician is there to make sure that that baby is breathing well. And if a baby isn't breathing, there's many different interventions that a pediatrician can take to ensure that this baby breathes. Now, what happens if a baby doesn't breathe? Now, we don't get oxygen delivery to the brain, and this creates something called hypoxic ischemic encephalopathy. Hypoxic meaning lack of oxygen, ischemic meaning lack of blood flow, and encephalopathy meaning brain damage. And this can happen in the first minute of life. Mm-hmm. So, as we say in the medical field, seconds do matter. And you don't want to have someone that is not trained to handle a baby not in the delivery room. So it's very important that a pediatrician is there at the delivery when a baby is being born. Now, a pediatrician is there solely for the baby and to transition from in mommy, which we mean inside the womb, to the outside world. and an obstetrician is there to take care of the mother, and that's where your role comes in. So there are two patients, so there are two specialists, but there are two specialists working as one team. Now, a baby's healthy life does not start from when they are born, but from even the minute of conception. So you tell me, Dr. Khan, what are some things that parents, and I mean parents, not just mom, but mom and dad, what are some things that they can do to give baby this best possible start in life?
So, very good question. And as you said, it's so important for us to recognize the need for both of us in the delivery room, as you said, because of the fact that I have to focus on mom, and I wouldn't be able to divide my attention between mom and baby. So, like you said, we would assume that a good healthy start to life starts with pregnancy and antenatal care. But in reality, and a lot of international attention is being drawn now to something called preconception care or preconceptual care. And this is endorsed by many international organizations such as the World Health Organization, the American Academy of Pediatrics, Royal College of Obstetricians, the American College, etc. And what exactly is preconception care? This is prior to pregnancy. This would involve and include interventions and activities to optimize maternal health before she becomes pregnant. So, for example, we know that many pregnancies are actually unplanned, and a lot of times women may present or go to their doctor, obstetrician, way beyond the first trimester of pregnancy. So what can we do? We promote and advocate for periconceptual care. That means seeing the couple, actually, because paternal health, so the health of the dad is also important, but especially maternal health. We take the opportunity to address everything from the maternal history. So mental health issues such as depression, anxiety, screening for disorders such as diabetes, hypertension, and anemia. So these are very common conditions that we see locally. Up to 1/5 of women, 20% of women can present with diabetes in pregnancy. So we need to address these concerns before and implement dietary lifestyle changes to maximize or ensure that the mom is in the best of health. She's using medications that may be required prior to pregnancy that is safe for pregnancy, because not all tablets are safe for pregnancy, and many would not be aware of that. In addition to which, we can also ensure that they are up to date with their immunizations or vaccinations, ensure that they are up to date with their pap smears. Family history is also important. So for example, genetic disorders, if there's a family history of babies with chromosomal disorders, Down syndrome, this is important because it can also occur with the current couple, okay? Even lifestyle, use of alcohol, smoking, illicit drug use, all of these can impact on the baby. So it's important to discontinue those things before. And importantly enough, even for the father, meaning the paternal health, this can also contribute to affecting sperm quality and sperm quantity, and therefore that could even impact on things like infertility or even miscarriages. So everything is very, very important. Even the prior obstetric history, if a couple has had recurrent miscarriages, ectopic pregnancy, or even stillbirths and so on, then all these issues must be addressed so we can plan for the future pregnancy. And lastly, supplementation. So it's so important for women to start using supplements such as iron, folic acid, and B12, the vitamin Bs, omega-3s, because this is important for the fetal brain development. Just to highlight what I've just mentioned, I am going to discuss a study that was actually published in an international journal in 2023 from a local population that was studied in Arima, in the Arima District Health Facility, with 366 women. And these statistics are very important, and I'd like to address it so we can understand what we just discussed. So this population included women between the ages of 18 to 45, so the reproductive age group, and Interestingly enough, 56% were between the ages of 18 to 29, whereas only 6.5% were more than 40 years. Over 50% had already conceived, so they already had children. And 62% were overweight or obese. So this means that according to the study, 96.7%, that is most of that population studied, had more than one risk factor for adverse pregnancy outcome. And these were being overweight or obese and impaired glucose tolerance or diabetes mellitus. So exactly what I just mentioned. 75% had a sedentary lifestyle, which means lack of exercise. 89% had a diet high in processed foods or fats, all the KFC that we love to have. And this other important point, 13% had planned to conceive. But of those who did not plan to conceive, 75% were sexually active, and 2/3 of those not using birth control. Over 57% never had a pap smear. So what do all of these statistics mean? It just highlights the fact that a lot of women, the younger women, are the ones who may not be using contraception, may not plan for their pregnancy, but yet there are risks. They can be obese, they may have prediabetes or diabetes and enter pregnancy that way. And they will not have any intervention before to maximize their chance of having a healthy baby. So all of these things are important. It highlights the need that we need to emphasize the couples to come for preconceptual care. And remember, this can be done in our public health sector, local health centers they can attend, or privately as well too. So I think this is very important for us to understand.
I definitely agree. Yeah, because a lot of people, they aren't aware that, these things even before the conception of a baby actually do help with the long-term development of a baby. And all these statistics that you've quoted, they're striking to me actually. 75% of women are just unaware. So
exactly. So one of my friends had actually, when I discussed that with her, she was like, well, no, we should focus on those who are over 35 years, because again, now a lot of couples are delaying pregnancy, maybe becoming older before they start their family. However, quite a majority we still see at the younger age. So as I quoted, 18 to 29 years old. And so it doesn't mean, yes, I agree, as a woman gets older, the risks are higher for certain conditions, but it can occur even in a younger population. So we can't exclude those, and we can't just focus on one subset of the population. Everybody at any age can potentially develop problems, and therefore it's important to focus on everyone.
I totally agree. Your healthcare starts from the minute you're born and all the way through adulthood. So definitely keep up with your regular health checks, and you never know, a baby might pop up sometime soon. So when this happens and parents do conceive, what are some things that they can expect in their antenatal care?
Right. So again, we are hoping that they attend for preconceptual care. So we would have optimized the chances. Once they become pregnant, it's very important. Pregnancy test is positive. You should visit. So your first antenatal visit ideally is done in the first trimester. So pregnancy divided into trimesters, trimester 1, 2, and 3. The first trimester until 12 weeks, ideally women should be seen within that 12 weeks. Why? Because again, we can do a dating ultrasound scan, which can confirm the pregnancy, whether it's one or more than one, so twins, triplets, and higher order pregnancies, the viability, and also the location, knowing whether it's in the right location or an ectopic. And the dating is important for us to plan, for example, if women need to be induced, we do not want to induce a preterm pregnancy. So dating is very important. We emphasize the use of folic acid, especially in the first trimester. This prevents something called neural tube defects. So that is abnormalities of the baby's brain and spine. Omega-3 as well too, for cognitive, development of the baby. So that's important. Having done all of that, we also screen we do blood investigations. So certain screening tests for things like HIV, syphilis, and pregnancy. Very, very important. The mother's blood type, as well as screening for iron deficiency anemia. In addition to which, now in the second trimester, there's a very important ultrasound scan known as the fetal anomaly scan. This is done between 18 to 22 weeks, and it's a very important test to determine for any physical abnormalities of the baby. However, that is different from what we call the NIPT screen, non-invasive prenatal testing. So this is now a blood test that can be done from 10 weeks onwards, screening for something different. So this is for chromosomal abnormalities, such as Down syndrome, which is one of the most common ones.
Correct.
For each trimester, once we screen women, if there are any medical disorders that are detected, especially diabetes, then we can discuss lifestyle changes, implement dietary modification, use of medication. Some women actually have to use insulin in pregnancy and monitor throughout their pregnancy. So this puts them into a category of what we call a higher risk pregnancy, and therefore they need more frequent antenatal visits. You know, they may need to be seen by a whole team of doctors, dietitian, the endocrinologist if necessary. Okay, and this is very important to maximize the best outcome. That's what's really, really important. I mean, once we reach that stage of antenatal care, and we are assuming we reached the 9 months of pregnancy now, what should parents expect in the delivery room or the operating theater? So baby is delivered and handed over to you. What next?
So we think, we hand over baby, we cut the cord, and we hand over to the pediatrician. Now, in my practice, I try to have the parents involved as much as possible, because I think it's unfair that we deliver this baby, and then you take baby across to the warmer, you dry off baby and everything, and mom is there trying to look to see, what is happening with her baby, because she's been spending these entire 9 months to see her very, very cute baby after delivery. And what I try to implement in my practice, especially for the normal deliveries, not speaking about the cesarean sections, is that as soon as baby comes out of the room, we place baby on top of mommy to encourage what is called skin-to-skin contact. And even before clamping of the cord, we try to promote something called delayed cord clamping. Now remember, while baby is inside of mommy, the baby doesn't breathe. And baby relies on the placenta flow to breathe for baby. So that delivers all the oxygenated blood to baby and make sure that baby's cells are all oxygenated and make sure that baby is perfusing well. Now, what we mean by delayed cord clamping is about 30 to 60 seconds after baby is born, we allow for a little bit more blood flow from the placenta into baby. And what does this help with? Now, this helps improving the iron stores in baby, thereby decreasing the risk of iron deficiency anemia. So even from a very early age, we can help prevent iron deficiency anemia, not having to start baby on any multivitamins or anything. And this helps with the brain development and the cognition of baby. What does this also do? It provides a smoother transition from, as I was speaking about, placental breathing to now lung breathing. And remember, baby has to cry in order to have proper breathing. And this helps stabilize the blood pressure and the oxygen delivery throughout baby's entire body. However, there are many indications where we have to avoid delayed cord clamping. If there are any emergencies, and I'm not just talking about the baby, but also with the mother. Right. So if baby is not breathing well, if baby still looks blue and baby needs some intervention, then we have to cut the cord immediately and take baby to the warmer and initiate different resuscitative mechanisms in order to make sure that baby breathes and that heart rate starts to pick up. And also, if there's a maternal indication, such as placental abruption, meaning that mommy is bleeding profusely, then we have to try to get that placenta out as quickly as possible and treat the maternal emergency. So while things are happening with the baby, that's where you come in to deal with the mother to ensure the health of the mother. Now, I spoke about skin-to-skin contact as well, and what does that mean exactly for the mother and the baby? Exactly what it says, skin to skin. So we make sure that we have no cloth on baby, try to take the apron off of mom and place baby against mommy's skin. So mommy provides warmth to that baby. It actually helps with reducing baby's cortisol levels, and this in turn decreases baby's risk of hypoglycemia, meaning a lower blood sugar. And this helps with temperature regulation as well. And even for mom, this allows for bonding immediately. So while baby is there, and
That's so important.
oh, it
That's
definitely
very
is.
important.
I think
I think
you've
so
been
that's-
waiting for so long.
Exactly. That's one of the, I think that's like the highlight of the delivery. You know, once they are able to have that skin-to-skin contact, it just, even for the mom, it reduces her cortisol levels too.
Oh, definitely,
You know?
definitely. It releases all the stress, all this hard work that you went through for 9 months. This is what the hard work was for.
And the excitement as well.
Exactly, exactly. And just hearing that baby cry for the first time is such an amazing feeling. The mom start to cry, the fathers in the delivery room start to cry. It's such an emotional.
Tears of joy.
Exactly.
Tears of joy.
So one baby is crying, and then we have 2 bigger babies that are crying as well.
Of course, of
Yeah.
course.
And then what do we do after we dry off baby and we warm baby, making sure that, you know, baby's temperature is regulated. So once baby has a good cry, then we try to do everything on top of mom there. So, well, me personally, in my practice, to be able to have that intimate moment between mother and child, also father. So we try to encourage the dad to cut the cord, or the mother, whoever's preference it is. But to have daddy involved even more, we try to allow dad to cut the cord once the delayed cord clamping has subsided. And then all this time sounds like, you know, it's a lot of time passing, but all this is done within the first
few
minute of
minutes.
life.
Oh, right.
Yeah.
Okay.
And in that first minute, we have to then assess baby. And how do we do this? Pediatricians, we have what is called the APGAR score. So sometimes you may hear people talking about, well, what are your baby's APGARs? And you hear random numbers, but it goes from 0 all the way up to 10. And this is a quick way to decide if this baby is doing well or if this baby needs intervention. So obviously a higher number means a very, very good outcome, and this baby is doing very good. So what does APGAR mean? What does it stand for? So the first A means the appearance of the baby. Not that the baby looking cute or not that it looking like mommy or daddy, meaning that is this baby pink or is this baby blue? Pink meaning that this baby is getting perfusion throughout its entire body, and it will take a while because remember, baby was not breathing inside, and then we have to make sure that this baby gets enough circulation. So by the heart working, we make sure that this appearance goes from blue to pink. And as I'm speaking about the heart rate, that's what the second letter stands for, which is P, which is the pulse. So we have to ensure that baby has a good heart rate, which for babies is ideally above 100 beats per minute.
Okay.
Then we go on to the G, which is for grimace. We want to see what sounds baby are making and what baby's face is doing exactly. If baby sneezes, if baby is crying, if baby is making, you know, those twisted, cute faces that we like to see in babies, that's called a grimace. The second A is for baby's activity. If baby is just floppy, you know that that baby is not doing much, or you want to see that that baby is very active. The more activity a baby has, you know that baby is doing much, much better than a floppy baby.
Right.
And then the R is for respiration. Respiration not just meaning breathing, but crying. So a good R means that this baby is crying very, very loudly.
Screaming a lot.
Yes.
So we will take a break, a little short commercial break, and we will resume right after.
Never too early, never too late to recharge and hydrate. Get your daily dose the right way. Grab our Oasis now, why wait? Never too early, never too late to recharge and hydrate. Get your daily dose the right way. Grab our Oasis now, why wait? The greatest, the safest Oasis for sure. Oasis, it's purer than pure.
Fruitopia, the drink that rocks your lunchtime. Fruitopia, Fruitopia, it's a drink that's high. The citrus punch, fruit punch tastes nice. Guava, pineapple, that give me a vibe. We no want nothing less compared to the rest. Fruitopia the best. Punch any thirst when it comes to the test. Perfect thing for my lunch. Flavors pack a punch. Fruitopia, Fruitopia, it's a drink that's hype. The citrus punch, fruit punch tastes nice. Fruitopia, the drink that rocks your lunchtime.
Try our new passion fruit flavor today. Taste the passion.
Come back to Doctor in the House, where I have my guest tonight, Dr. Warris, and we are discussing the important role of the team of the obstetrician and pediatrician in the delivery process. So, resuming where we had left off, you were talking about the APGAR scores.
Right. Now, this gives pediatricians a gauge as to how well this baby is doing. And as I said, it's a score of 10. So A is 2, P is 2, G is 2, A is 2, and R is 2. So your highest score could be 10. Now, what happens when this score is a little less? Now, even before that first minute, do we have to fully assess baby and see exactly what is happening? Because remember, as I said, that first minute of life shapes the entire lifetime and the future of a baby. So we want to give baby this best possible start. Now, we check APGAR scores at 1 minute and 5 minutes after, but you see how critical that first minute is. So if you have a low APGAR score, there are different interventions that a pediatrician can take. But even before that 1 minute score, we want to give baby that possible best score. So in the first seconds of life, we assess baby, make sure baby is breathing. So the steps that pediatricians take when a baby is born is to warm that baby, dry that baby. If the baby isn't breathing or isn't crying, we stimulate that baby. So that's where you say, you give baby a little rub. No, we do not hold baby by his legs and we beat baby on his bottom. We just rub baby enough so that we stimulate baby and try to elicit a cry. And then if that isn't working, we have to do necessary interventions to try to get that breath into baby's lung. So the first thing is we want to make sure those airways are clear. Now remember, inside of a mommy, baby is literally swimming in fluid. So sometimes some of that fluid can be still trapped within the nasal passage. So we have to try to clear that nasal passage as much as possible, and we try to do that by stimulating baby to cry. Now, if baby isn't crying, we can use necessary interventions such as suctioning to try to clear that airway. So we clear via the mouth and via the nasal passages. So we try to eliminate whatever fluid there is to see if that was a problem for why baby wasn't breathing. If this doesn't work, we can give what is called bag and mask ventilation. So I know that's something very scary for parents to see. So in addition to me taking care of baby, I always face questions from the parents, is baby okay? Now, this happens so quickly. So if baby isn't breathing, we have to try to get some breaths into that baby's lung and try to deliver oxygen to baby's brain. So we do that via bag and mask technique, and then we do that for a certain length of time. Now, I won't get into the nitty-gritty of it, of how much seconds we have to do this for versus what the next steps are, but it's very, very important, as I said, to have a pediatrician in that delivery room to know exactly that protocol that we follow to ensure that baby has a first breath and to ensure that the baby has a good cry. And then after we listen to that cry and make sure baby is good, we take baby back to mommy, ensure that baby is well, give that 5 minutes APGAR score, and then we have some bonding time again between mom and baby and the father.
Right.
So we allow for as much time as possible bonding there as permitted. And then after we do that, of course, you have your job to do with mom to take care of mom. So while that is happening, usually what I do is we take baby up to the nursery, and I take the father with me, so we do a full and a thorough exam on baby, and we make sure everything is good with baby. So this is where daddy gets his little bit of one-on-one time with baby. So when we take baby to the nursery, we do our full examination with baby, and it's a head-to-toe examination, looking for any signs of dysmorphisms, anything that is wrong with baby, and making sure that this baby has a very good examination, and there are no concerns with baby. And in addition to this, we also do baby's weight, baby's length, what is called the head circumference, and if necessary, certain interventions. So you were speaking about how we have a high prevalence of diabetes. And if a mom is diabetic, that actually puts baby at risk of having a low blood sugar. So we could check in the nursery what the baby's blood sugar is. And then in addition, we give baby what is called vitamin K. Now, what is vitamin K? Vitamin K is a vitamin that is very deficient in newborns, and this is very important for babies' clotting of his or her blood, and we give it via an intramuscular injection, usually into the thigh, and this is to allow for a boost of their vitamin K in order to ensure that this baby doesn't have any life-threatening bleeds. because we would get a little cut and then we heal well. But that is because we have gotten our vitamin K injection, and adults are able to produce vitamin K much better than babies are able to. So we give them that boost, so in case of any life-threatening bleeds, baby has that extra vitamin K to help with clotting of the blood itself. So after this process, we try to figure out, okay, well, what is happening with mom? So you tell me, Dr. Khan, what are some factors that can affect the delivery process?
Okay, sure. So we've reached 9 months of antenatal care, and then the next step obviously is delivery. And it can be divided into the time of delivery and mode of delivery. So most women can go into spontaneous labor. So you have vaginal delivery and you have cesarean section. Unless there is any medical complication, such as, for example, diabetes in pregnancy, hypertension or preeclampsia, or even growth restriction, so the baby is much smaller than we anticipate, or things like multiple pregnancy, twins, if the first baby is not presenting with the head down, those are some indications that we would want to either deliver, induce, so meaning we don't await spontaneous labor, but we give medications to bring on contractions, or we opt for a planned cesarean section. With regard to the vaginal delivery itself, the whole process is centered around the 5 Ps, as we call it. So the 5 Ps will be the power, passage, passenger, the position, and mommy's psyche. So with regard to power, it's important for vaginal delivery to have adequate frequency and intensity of contractions so a woman can dilate and be able to feel, to reach full dilatation to deliver. With regard to the passage, maternal build and the pelvic shape and size is also very important for the baby to be able to pass through the passage. And we only can assess that at the time of labor. We can't assess that antenatally. Thirdly, the passenger. So if the baby is, the average birth weight is between 5 to 8 pounds. A very large baby is over 8.5 or 9 pounds. Very small baby is less than 5 pounds. If the baby is bigger, it's more than likely, especially if it's a first delivery, sometimes it's not possible for the baby to pass through the passage. And also the position of the baby. So if the baby's head position is not correct, or it's tilted, or it's in a malposition, it may not be possible as well too. In the delivery room, support is very necessary. So women have their husbands, their spouses, partners present, even someone else like a sister, mother, a doula. All these people can be present to provide emotional support for their mom, as well as pain relief is extremely important. So we offer epidurals, for example, for those who would like it, or even the use of opioids, which are strong analgesia during the labor process to facilitate it. If, however, for cesarean section, sometimes we have planned versus an emergency. So, I mean, there is, for example, our case from last week. We had the patient who came in labor. She actually had what we call spontaneous rupture of membranes. And during the labor process, she will give him pain relief, and we monitor the baby during the labor process. So this is putting her on a machine known as the CTG machine. And this allows us to monitor both contractions as well as the baby's heart rate. In certain cases, like that particular patient, the heart rate was dropping and was not picking up adequately. And while we were monitoring that, we realized that she was not progressing, so she was not becoming fully dilated. So after a certain period of time, a decision had to be made for the interest of delivering the baby safely and preventing any oxygen deprivation. And therefore, she had to have a cesarean section. So even during the labor process, women can sometimes end up having an emergency cesarean for the delivery, safe delivery of the baby, and to ensure that mom's health and baby's health is preserved. You know, one of the things that we had discussed previously, why you said that it's crucial, every minute counts and every second counts. So during the labor process, we can have emergencies that arise in a patient who was low risk and everything was going well, and then suddenly there's something called cord prolapse, or there can be something called shoulder dystocia. These are emergencies that have to be dealt with within seconds. Otherwise, there can be detrimental effects to both mom and baby. And that's hence the importance of having you there as well, so that we can ensure that baby's taken care of while we focus on mom, for example. And seconds matter.
Yeah, as we say, 2 specialists, 2 patients, and 1 team. Because while you are focusing on the mother, that can give me time to focus on baby, and you don't have to try to focus on who is taking care of baby and
Baby at
what
the
is
same
happening,
time.
and making sure that baby is well taken care of.
Yeah. So in the first 24 hours after delivery, what is it that is important for you to observe before the baby is discharged?
So we usually say 24 hours. Sometimes it can be a bit less, but usually 24 hours is what we give pediatricians to monitor baby and observe baby and ensure this baby is doing everything that is necessary to be discharged to the parents at home. Because we don't want to discharge a baby and then they have to bring back baby to the emergency department or to the pediatrician's office in a very short period of time. So you want to be able to discharge baby and only see you for your regularly scheduled visits. Now, these things that we look out for to make sure that baby is breathing well first. Yes, we ensure that baby is breathing well to deliver that oxygen to the brain in the first few minutes of life, but even after these few minutes, babies can have some sort of respiratory distress. And remember, this baby, as I was saying previously, that they're literally swimming in fluid. So they need to try to eliminate as much fluid. So you see a little bit of bubbles and stuff coming out, so you want to make sure that this baby is breathing adequately and clearing these extra secretions from their nasal passages. And then sometimes this can develop as some fast breathing or what we call nasal flaring. And you just observe baby until this resolves on its own, or if it doesn't resolve on its own, we take necessary interventions. Another thing that we look out for is to make sure that this baby is regulating his or her temperature properly. So we can't send home a cold baby, or we can't send home a baby with a fever. So both very different things. A fever in a baby is an emergency, so we have to make sure that this baby is regulating his or her temperature well, and then on the flip side, making sure that this baby isn't cold, because that is very important, because that can affect baby's feeding, baby's development in the long term as well. Now, speaking about baby's color, so we want to make sure that baby doesn't have any signs of turning blue. And then why is this important? Because this gives us an idea of how well baby's heart is working. So as I spoke about previously with the neonatal examination, we examine baby's heart and look for any signs of any cardiac abnormalities which may need to be treated within that neonatal period. Now, very, very uncommon, but still it can happen. So in this first 24 hours of life, these are things that we do look out for, and we test what is called baby's SpO2. This is baby's oxygen saturations, and it gives us an idea of how well this baby is perfusing his or her body.
Right.
Now, then we have the simpler things. Make sure this baby is peeing, make sure this baby is pooping, crying, feeding well, and sleeping. So if you are a patient of mine, I would tell you that baby has all of 5 things that they need to do: to feed well, to sleep well, to cry, to pee, and to poop. And that is all that baby's job is. I know there are some daddies out there.
And repeat.
And repeat. But I do know that there are some daddies out there that they wish that was their job and just, relax all day.
Right.
But this is very, very important, and a easy little checklist to make sure that baby is doing everything that they're supposed to be.
Sure. Very good. So we have come to the point where baby is doing really well.
Yeah.
And we are happy to send home the mommy, daddy, and baby together. After baby is discharged, what should parents look out for in the immediate neonatal period? Are there things that they need to look out for?
Definitely, because it just doesn't stop there. Because remember, there are different things that can happen with a baby when that baby is discharged. So the first thing that we usually look out for and that I advise parents about is signs of jaundice. Now, what is jaundice? Jaundice means any yellowing of the baby's eyes or of the baby's skin. Now, that doesn't mean the brown part of baby's skin or the white part. Then it looks at below the surface of the skin, and that changes color. And it goes from the lightish color that baby has to a deeper yellow color. And that occurs because there's a lot of breakdown of red blood cells that is within baby. Now remember, baby was receiving all its circulation from mom. Now all this red blood cells starts breaking down and releases something called bilirubin into the bloodstream. Now we think, okay, it's just a little bit of yellowing of the skin. What's the worst that can happen? There's a lot that can actually happen if we leave jaundice untreated. Now, jaundice can actually cross into baby's brain and affect baby's brain, and that can affect baby's long-term outcome and affect baby's development.
Sure.
So people will say, well, doc, why don't you just walk baby in the sunlight? Because, you know, that's what we told, that to prevent jaundice, you walk baby in the sunlight. Now, jaundice ranges from very low levels to very high levels. Now, yes, sunlight can treat very low levels of jaundice, but very high levels of jaundice need very specialized treatment. Now, this treatment usually is from the phototherapy, and that's the blue light that we put on babies. It's a UV light that helps break down this bilirubin into a version that can be easily excreted. Now, it's very important that the first sign of jaundice, you bring baby into the emergency department or to your pediatrician's office. Why is this so important? Because we can't tell just by a little bit of yellow or a lot of yellow how high those jaundice levels are. If you see any sign of yellow, you bring baby straight. And then we have to test baby either by putting a light on baby's skin or by taking a blood test, which is a little more accurate. And that gives us an idea of how high these jaundice levels are. And based on those levels, we can determine if we do need to treat baby with the UV light, if we can let baby go home with just the sunlight therapy, or if we need to bring this baby back in for a further test to see where this jaundice is going, if it's going up or if it's coming down.
Right.
Now, when we say do the sunlight walks, we have to be very careful because remember, we're taking our newborn baby into the sun, and our Trinidad sun isn't very nice. It's very, very hot. We feel hot outside, so we can imagine how these babies feel. And yes, babies can overheat. So be very, very safe when you're taking baby outside, only for short periods at a time. And what we try to say is try to avoid direct sunlight. So if you're inside, like next to a window, you say, okay, we could put baby next to the window and have that sunlight coming through there. But that as well can cause baby to have a little bit of overheating. But jaundice is very, very important to look out for. And please, if you do see any signs of jaundice in your newborn, please visit the nearest health center, emergency department, pediatrician's office, wherever you can take baby to.
Sure.
And
then there are, well, of course, besides that now, there are other things that we should look out for, right?
Oh,
so you could discuss
definitely.
some of those?
Yes. Another major thing that we look out for in neonates is any signs of infections. Now, the first sign of infection usually that we see would be a fever in a neonate. Now, a fever in a neonate is an emergency, especially in a baby less than 1 month of age, because this baby doesn't have much of an immune system and they can't fight off infections like how we are able to fight off infections as an adult. So we have to ensure that this baby doesn't have a life-threatening infection. And as I said, the first sign is usually a fever. So where do we check the temperature? We use one of those thermometers, put it on the baby's arm, and then if it's a temperature above 38 degrees Celsius, or if you're using Fahrenheit, if it's above 100.4 degrees Fahrenheit, that is a fever and that requires immediate intervention.
Okay.
It's not that you just give baby a dose of Panadol, the fever comes down and we're happy. No, so we're treating the fever with the Panadol, but we're not treating the cause of the fever. And the cause of the fever can be the life-threatening thing that we definitely don't want to happen. So we bring baby into the emergency department, we assess baby, ensure that there's nothing life-threatening, and then start baby on necessary medication if necessary. Now, another sign of infection that we can look out for in a baby is around the umbilical stump.
Right.
So we know that that umbilical stump is attached to baby, and it's very important to take care of that cord when we go home to ensure that this baby doesn't get any infections. But remember, with all the cord care that we do do with baby, there still is a chance of an infection happening. So what are signs of infection? You look out for any redness around the umbilical stump itself or any pus coming from that umbilical stump. And that in itself is an emergency that you have to rush baby into the emergency department for.
Sure.
Now, if I was to sit here and chat with you about all the different possible things that can happen with a baby in the immediate neonatal period, we won't finish in a day's time.
We'll need more than one session.
More than 3 sessions, because
Okay,
there
sure.
are many different things that can
Sure.
happen with a baby in that immediate neonatal period. And please, if you do notice anything that you're unsure about, or you just figured like, you know, this is something that we do need a checkup, please take your baby to the nearest health institution. I love to tell parents, it's better you take your child up, you run out the door, jump in a car, head to the emergency department. Some parents like to say, okay, well, let me call the pediatrician's office, find out if they're there, get a little bit of advice and find out, should this be something that I should bring my baby into the hospital for? Seconds do matter.
Right.
And that is one of the major takeaway points for today.
Sure.
Especially in a baby, those seconds matter. And we want to make sure that baby is on his or her way into an emergency department to receive that necessary care.
Sure. Could you mention something quickly about SIDS?
So SIDS is called sudden infant death syndrome. And what that is by having baby placed in the proper sleeping position.
Right.
So we always think, okay, well, we have fed baby, we put baby down to sleep, and we think, okay, well, what if this baby vomits? Wouldn't it be better that we have baby face down, so if baby vomits, the vomit comes out? But actually, if we put baby face down, sometimes that can actually promote spit-ups or vomiting. If a baby is face up, they usually have a less likely chance of vomiting. But in the sleeping position, why we say always face up is because if you have that baby face down, then that nose and mouth can become obstructed by the bed. Baby gets no airflow into the lungs itself, and that's how babies actually suffocate in their sleep. It can happen instantaneous, and we're asleep, baby is asleep, and it happens so quickly, and then we wake up in the morning or wake up to feed baby and realize that this baby isn't breathing. And it's a very, very sad thing, but it's actually the most common cause of death in a neonate less than 1 year of age.
Okay,
So
sure.
it's called sudden infant death syndrome, SIDS for short, or CUT death.
Okay.
So very, very important. Rules for sleeping is always have your baby face up, and then what babies usually do is that they have their head tilted to the side, and that allows them to have any spit-ups coming out the side of the mouth if,
Right.
in fact, they do spit up.
Right,
So
sure.
very, very important to have baby face up. Make sure that there's no pillows on the baby's head, because if you look at a baby's neck, there isn't much of a neck, right? So baby can actually have a pillow under his or her neck. They could bend the neck like this forward, and that kinks their airways, and babies can suffocate like that.
Sure.
And also, if you're using blankets, make sure you have baby tightly wrapped in that blanket. So very, very safe to keep baby swaddled. You keep them in that fetal position, they sleep much better, and they have a very restful sleep. So 3 rules for sleeping babies: face up, flat surface, tight blanket.
Sure. So, very elaborate discussion this morning, this evening. Can you just summarize for us what would be the take-home messages for today?
So take-home messages: seconds do matter. Please, in that first neonatal period when baby is born, you want to make sure that you do have a pediatrician in that delivery room, because when the expert care matters, you want that person there in the delivery room to ensure you give that baby that best possible start in life. And then working together with you, we always say there are 2 patients, there are 2 specialists, but we work as one team.
Yes, very, very important. And also the fact that a healthy start to life actually starts not only in the antenatal period, but long before that, which is preconceptual care. So I would like to thank you very, very much for coming on board with us today. And I would love to have you again to present so we could discuss in further detail. So It was a very elaborate discussion, and I appreciate you attending and giving us your expert knowledge and sharing your time with us.
Thank you so very much for having me.
Very welcome. And I'd also like to thank our team of the IBN crew and the camera crew for your dedication and continued service to us. And we look forward to subsequent programs again. My next program will be on discussing on infertility. So thank you very much. Pleasant good night to everyone. Assalamu alaikum.